learning more and more that there are a lot of biologic differences between abiraterone and enzalutamide. And even though these drugs target the same pathway, they do so in very different mechanisms. And one's given with a glucocorticoid chronically for a long period of time that we're not doing in the other setting. So when I think about the ERA-223 data, it's important to recognize that that was done in the context of abiraterone and prednisone, not in the context of enzalutamide. The PEACE-3 trial is really looking at this now in a similar disease setting, but with a very different agent. And I think that's a really critical piece of this. There's one other aspect to the PEACE-3 trial that's really critical, and that's the timing. The timing now in the PEACE-3 trial is for the hormonal therapy, the enzalutamide, to be added first, and then 3 months later for the radium-223 to be given. That window in time may be fundamentally different than what was done in ERA-223. Again, ERA-223 was done not as our standard of care. This was done in a much earlier disease setting, an asymptomatic or minimally symptomatic disease setting, at the very initiation of these hormonal therapies. And that may have a different biologic context to the bone and even the non-cancer environment than in patients that have gone through treatment now for a number of months and maybe stabilize that circumstance. So again, I think there's enough differences between the drug enzalutamide and abiraterone prednisone, between the timing of these agents and what we know now. And importantly, in PEACE-3, all of these patients now are really encouraged to take bone strengthening agents as concomitant support. I think all of those differences could result in a very, very different outcome of that study than what we see with ERA. And that's what we need to know. Probably the most important thing to take away from what we just covered is don't be afraid to treat your patients. Don't be afraid to treat your patients with performance status 0 or performance status 1. Don't be afraid to treat your patients with multiple different treatment options, in sequence or in layering. What you should be afraid of is these patients dying from this disease, which for the vast majority of patients will happen within 2 to 4 years of being diagnosed with metastatic castrate-resistant disease. That may seem like a long time, but that last 6 months of that, there's no treatment. Their performance status 2 or worse their last 6 months, and if there is treatment for these patients, it's not helping. So we have a tighter window to treat our patients than we frequently realize with even in these patients performance status 0 or 1. They may have had a long natural history of disease up to this point, but the biology of castration-resistant metastatic disease is different. So treat your patients, treat them in sequence or in layering. Don't be afraid to be proactive in using these agents. Treat in a multidisciplinary manner. And that means, for me, given radium, I don't write for that drug. That's something that I have other specialists do, and they're involved. And that's why I say this is multidisciplinary. Same thing with chemotherapy for our urologists. This is a partnership. This is not, okay, now the patient's yours. This is a partnership. These patients have a long-standing relationship with their urologist. They have long-standing urinary issues that need to be continued to manage. They're going to look to those physicians for guidance in the treatment decision. Who actually gives the drug? It's actually the nurses. None of us actually give the drug. So thinking about management as a team, palliative care. We've probably underutilized palliative care in many of these patients. Don't think of palliative care simply in the last 3 months. Think of palliative care as preventive care. What are the things and symptoms we want to be doing so we can continue these patients on treatment and get their performance statuses back up? These are really critical. Think about bone health. Bone health is probably one of the complications that can lower performance status to the point that we can't treat these patients anymore. And preventing that, not at the time of those complications, but 3 to 5 years earlier is really critical. So thinking about bone health early on in their hormone therapy is, I think, a really important piece. Many urologists are excellent at this, but listen, we're all human and we all need the reminders, and none of us are perfect. So it's a great opportunity for us to really look back and say, how can we really improve the life and extension of life for these patients?